Hello and welcome to Quality Bites, brought to you by the Quality Improvement Team at Bradford Teaching Hospital Foundation Trust. This is one of our series of bite-sized training videos for BTHFT staff. Each video introduces a quality improvement topic or tool which can be used to support quality improvement projects across the Trust. This Quality Bite is going to focus on two commonly used terms in healthcare, namely clinical audit and quality improvement. We will explore the differences between them, and at the end of the video, you should understand when to use audit and when to use quality improvement. To start to understand the difference between clinical audit and quality improvement, we first need to understand the difference between quality assurance and quality improvement. Both quality assurance and quality improvement are essential elements of the quality strategy here at BTHFT, and both help us with our learning. But clinical audit is in the quality assurance paradigm as opposed to the quality improvement paradigm. Quality assurance is about meeting a standard. Standards are often set nationally or internationally, and the ability to meet these standards, plus how we benchmark against others, is an important way in which we assure the quality of the services we provide. Quality assurance assumes that if serious failures are inspected and eliminated, what remains is somehow excellent. This is sometimes called the bad apple theory, where the focus is purely on the outliers and not on the sample as a whole. Quality improvement, in contrast, improves all of the sample, which not only leads to a larger improvement in the average, but also decreases the amount of variation. It improves all, regardless of the starting point. The difference between quality assurance and quality improvement is benchmarking versus continuous improvement. The main difference between audit and quality improvement lies in how we collect data and how we implement changes. In a complete audit cycle, which must include the re-audit phase, data is collected at 2 points in time, which are often several months apart. We don't know what is going on during the time gap, as we have no data to tell the story. We also can't be sure if either data sample is truly representative of practice or if they are outliers that we happen to catch. In audit, changes are also implemented rather than tested. Often several changes are implemented between the audit data collection points, which means that even if improvements are seen from the re-audit, we never really understand which change has resulted in the improvement, or indeed if any of the changes have resulted in improvement. It may just be a coincidence. This makes replication difficult. Quality improvement, in contrast, is a continuous process represented by continuous data collection and continuous testing and learning through Plan Do Study Act or PDSA cycles. Data over time will capture performance over many more time points and therefore many more conditions, providing a more representative picture. Changes are also tested prior to being implemented and evidenced by continuously collecting data. These changes are much easier to replicate because we know they have led to an improvement. Remember, all improvements are changes, but not all changes are improvements. Both clinical audit and quality improvement need baseline data to understand where we are, and both will let us know when we have arrived. But we never completely know how we've arrived with clinical audit because we don't test the changes in a systematic way. Only quality improvement helps us with where we are going and that bit in the middle, which is a vital bit of the jigsaw we need to understand. Let's look at a real-life example. This is an extract from the National Adult Clinical Asthma Audit from a couple of years ago. In a complete audit cycle, you would re-audit against the same standards at month 12 to see if there had been an improvement. You may try lots of different interventions during that time and see an improvement at month 12, but you won't know which intervention gave you the most improvement. Now let's look at the same audit through a quality improvement lens. It would be reasonable, based on month 1 data, to prioritise working on the first standard, which is assessing patients for asthma severity, which includes measurement of peak flow within 1 hour of arrival. We would measure our progress towards the standard every month while testing our change ideas using PDSA cycles, plotting the data on a run chart and annotating which PDSA cycle allows us to clearly see which change led to the greatest improvement. For example, when the stock levels of peak flow meters were increased and the pharmacist took over ordering, there was a 14% improvement over a 3-month period. When the educational interventions at handover started, there was an 18% improvement over a 2-month period. So, to summarise, clinical audit and quality improvement ask different questions and so will get different answers. Clinical audit asks, how are we performing? Whereas quality improvement asks, how do we best actually improve? Clinical audit allows us to benchmark, whereas quality improvement gives us continuous improvement. Clinical audit measures are at fixed intervals, whereas in quality improvement, we measure continuously. Clinical audit doesn't recognise special causes or situations that make conditions less stable, whereas quality improvement finds them and adapts the response accordingly. But both help us learn. Clinical audit gives us the assurance we need, but it can also be used at the start of a quality improvement project to help us understand the problem. It is a fantastic foundation to build upon, then quality improvement takes us beyond that and can help us reach outstanding. In simple terms, use audit to work out if you are as good as you think you are, then use quality improvement to make the service even better. This brings us to the end of our Quality Bites from Audit to Improvement. We hope you have enjoyed it. For more information, or if there is anything you'd like to explore further, please drop us an email at qualityimprovement.team@bthft.nhs.uk. Bye for now.